and welcome. It's Deuk Spine Institute, and it is March 26, 2024. I'm here with Dr. Patel, Dr. Davis, Dr. Berndes, our whole team. We're getting ready to perform the Deuk plasma rhizotomy for sacroiliac joint pain and dysfunction. Our patient has had a fusion done. We did not do the fusion. Somebody else did, but ultimately he's having pain in his SI joint. I'm going to put some numbing medicine under the skin. We're not numbing his joint, we're just numbing the skin. And I'm going to do that on both sides. Our goal here is to get rid of the pain he's having in his sacroiliac joints. Sacroiliac joint pain can be debilitating, and as a result of the SI joint pain, people have a horrible quality of life. I need to see the right S1 shot. Can you rotate the fluoro or something? The L5 dorsal ramus shot. Other way maybe. Shot. All right. So, Jordan, you know what we need to see, right? So help me find it. I think you're going to have to rotate the fluoro that way. Shot. All right, we're going to spend a few minutes trying to get our landmarks down. Maybe bring the fluoro towards me. Move it north a little bit. Shot. That's probably as good as we're going to get it. What do you think, Dr. Patel? I like it. All right, so we're going to make an incision. Our incision is about 4 millimeters. And I'm going to use my probe to basically destroy the pain nerves to the joint. It's called a rhizotomy. And rhizotomies have been done for years by surgeons, doctors, pain management doctors, surgeons all over the world. But the problem is they don't work. Why? Because the actual concept of doing a rhizotomy, although it's a great idea, the doctors rarely actually perform a rhizotomy because they're not able to destroy the pain nerve because the pain nerve is not easy to destroy. So, in theory, it's a great idea, but in practicality, it doesn't work. Shot. All right, too medial. There's a lot of scar tissue, by the way, because of the hardware that we're dealing with here. What do you think, Patel? More lateral, right? It's got a very lateral dorsal ramus, L5. Could it be that I have to be a lot more lateral? Again, I'm feeling hardware and scar tissue. Let me have a Raytec.
Yes, sir.
Shot. All right, that's looking pretty good there. I just need to get down to that spot. Shot. Too high. Shot. That's looking better. Getting there. Shot. What do you think, Patel? Huh? Yeah, there's a massive amount of scar tissue here. Shot. But that said, shot. So this is on a scale of 1 to 10. This is a very challenging rhizotomy for the SI joint because of all the scar tissue from the screws. Shot. Sean? Now feel free to ask questions if you'd like. While we're working on getting down to the first nerve we have to destroy. Shot? What do you think about that? That's probably the best one we got so far, right? Yeah. I feel bone. The problem is I don't know if this is normal bone or fusion bone. So let's hope it's normal bone. Because if it's fusion bone, then it doesn't mean we're in the right spot. So, all right. Well, that was the hardest one I think that we're going to encounter. Shot. Next, we're going to march our way down and basically destroy these pain nerves as we go down. Now, these nerves normally innervate the SI joint, and they tell us if the joint has, pain coming from the joint, if you injure the joint. Well, this joint has been injured. That's why he has pain. So there's no doubt the joint's injured. The problem is when you have a painful joint, it takes control of your entire life, and it prevents you from doing the things you want to do. In other words, we already know the joint has arthritis, right? It's already been damaged. That's great. Your brain doesn't need to be reminded of that every single minute of the day. So, rhizotomies are a way of disconnecting a painful thing from your brain. Now, some people think, oh, but aren't you going to damage the joint more? No. The joint is already damaged maximally. You can't possibly damage it more. So, the good news is the joint is still viable. It just needs to be disconnected from your pain centers. And that's what we're doing. Disconnecting it. Shot? So that you don't have to live in pain. All right. Just about done here. I've marched. And the most important nerves to disconnect are the L5 dorsal ramus, the S1 and S2 dorsal rami, right, Dr. Patel? Yes. So, now, Dr. Patel is an expert on interventional pain management. He's my partner. We've been working together for many years. And I think it's going to be your turn next, Dr. Patel, to do the other side. Dr. Patel is assisting me with this procedure. I will tell you, let me do the first one. So let me, I've already put some numbing medicine and shot. All right, we're going to the other side. Let's get it lined up like we did this one. Shot. Now if I could only see, I need to see up here, Jordan, right here. Shot. You're going to need to go further north, Jordan, with your base. That's it. Shot. All right. Now, I need to see that side over there. Maybe pull it towards you more. So it's very important, folks, if you're going to do procedures that use navigation. Now, try orbiting different ways and see what works. If you're going to use the, is that it right there, Patel? Wait, go back. Shot. You think that's it right there, just to the left of the bottom screw head? All right, so we can work with that. It's not ideal, but it is workable. Shot. I wonder if I need to be more lateral or superior. Shot. How's he doing, Dr. B? All right, well, I got to get around those screws, so let's hope this works. Shot. I may have to make 2 incisions, but I think this will be okay. Incision is being made. Second one. I'm going to use a property of our skin. Do we have any questions, Henry?
Yes, we do. This comes from Lanu on YouTube,
Hello, Lanu. Welcome.
asking, do you ever get hungry during a surgery?
I do, actually. It's funny you ask, Lanu. I do. As a matter of fact, it's odd, isn't it, to get hungry during surgery? But it happens. It happens, and it's okay. I mean, I don't get hungry because of the actual surgery. I get hungry because, well, like everybody else, I have an appetite. It is independent of the actual surgery itself. Shot? All right, 2 medial. Yeah, if you want to bring us lunch, you're welcome to. Shot? Shot? I'm trying to get down to the spot that I need to be at. And again, what is that? Shot? I'm getting closer. And what I'm having to do, just so you understand, there's something wrong with the machine. Okay? Shot? Well, no, you got to check the patient's thigh, make sure the grounding pad is still there.
And also, boom, boom. Pull it on the other way. One second. Let's see. Inverted. There you go.
Shot?
That's good. That's good. Whatever you did is good.
Okay.
See?
No. Do we another round?
Round.
Shot? All right, we're pretty darn close.
Yeah, there's another round there.
I got it.
Any other questions?
At this moment, no current questions.
So we're close to where we need to be. It's not perfect, but the problem is the screw is forcing me to the side. And let's see where we are here. I'm going to try again.
You did it.
I need to be.
Awesome. Thank you so much. Thank you. All right. Okay, good. Let's see.
Tremendous amount of scar tissue I'm trying to work through here from his prior surgery. Tremendous. It's extremely challenging. All right, are we ready?
Let's see it. Yeah, hit it. Yeah, good.
Shot. It feels like I'm on bone there, shot, which is good. You always want to feel like you're on bone. And you want to be on the right spot. And there's a little nerve that runs right through here. And I'm literally rubbing against the metal. I've gone as far as I can laterally. And now I'm going to go back medially. And I'm using my technique, the Deuk spine technique, where you hop with the probe up and down just to make sure you get that pain nerve. Okay, I feel pretty good about that. Now I'm going to work my way down to the lower areas. Let's see where we are. Shot? All right, so we're just lateral inferior to the first foramen. All right, Bharat. Have a feel at that. Any questions from the audience?
At this moment, no current questions.
Yeah.
We just got a question.
Let's see where you are.
This question coming from Lanu, once more on YouTube,
Hi, Lanu. Nice. I would go north a little bit.
asking, do former patients or businessmen ever send pizza or lunch to everyone at Deuk Spine?
Yes. Yes, as a matter of fact, they do. Thank you so much for asking. Yeah, we get lots of gifts. You know, I got to be honest, it's one of my favorite things is to get a gift, not because I need it financially, but because it really shows that patients are thinking about everybody and are very appreciative. And it's funny because my father was an OBGYN. He delivered babies, and he got tons of gifts from his patients. And, you know, I never got gifts from patients when I was doing fusions. Just once in a while I get a gift. But now we get a lot of gifts, and patients love us. Don't bend the tip too much.
Let me have another one. This is too long.
Too long.
Too long. Another one, please. Thank you.
Yeah, thanks for asking. And if you want to send us pizza or donuts or candy, we get the fruit. What is that fruit thing called? That's like a flower arrangement with fruit. Edible arrangements. We like those. We've gotten Chick-fil-A. We've gotten a lot of stuff. So we really love it when our patients do that. Now, so just to reiterate here, I want to talk for a moment about the SI joints. Can you guys, Jordan, show us the SI joint. Henry, can you see this image? All right.
Yes, we can.
Now look at the arrow. That's the bottom of the SI joint. Now run it up. All right. Is that right there, Patel? All the way up to the top. And there. Yeah. Yeah, so you can see the anterior and the posterior parts of the joint. It's a big joint. Yeah, that's it. So that joint gets arthritis, particularly after fusions, like this patient had at L5S1. People get horrible SI joint pain. And let me have the coker. And nothing takes it away. You can do an injection of the SI joint, all right? You can do an injection of the SI joint, and you can get rid of the pain temporarily. But the pain always comes back, Shot. And the only way to really get rid of the pain is to basically either fuse it, which doesn't work, or to do a rhizotomy like we're doing now, the Deuk plasma rhizotomy, which is a special kind of rhizotomy. And this rhizotomy is done with a far more powerful probe than the RFA probe. So where the RFA probe fails, the Deuk plasma rhizotomy works. Okay, and we've patented this procedure, by the way. So, damn. Where is the other ones, Luis? I thought we agreed on using the other
You
probe.
want the blue one? This is the blue one.
The one that doesn't melt.
This.
Huh?
The blue one. This one.
This is it.
This is it.
All right, well, there you have it.
You want another one? Or this
No, we could use that one. I'm just going to have to tent the skin up a little bit so I don't coagulate it. Shot?
We have another question.
Sure.
This comes
Shot.
from Amartos on YouTube,
Amartos, yes, of course.
asking, do you
Shot.
ever plan to do certain sections for the rhizotomy, but then notice during the procedure through X-ray or feel you have to do a different section or have to add a section, like planning C3, 4, 4, 5, but then you think C5, 6 has to be done as well?
Yeah, let me just answer the question. Never. Amartos, honestly, a good surgeon never changes their plan in the operating room when it comes to these types of surgeries. Now, if you're taking cancer out of somebody, you could be surprised, right? And you may end up, seeing something that you didn't expect, or you may have instability you didn't expect, and then you have to deal with it. And if that's the case, then you have to do additional work, right? But with this type of surgery, we're talking about degenerative conditions. There's no reason, in my opinion, to have to do more. I could tell you, I could count on one hand the number of times I've changed and added something. It's literally maybe once in my entire career. So if you go to a good surgeon, a good doctor, they should know what they're going to do ahead of time without having to change plans. We're done, yeah. We're done. So I'm just literally scraping the bone. Go ahead. Just lateral to those foramen, up and down, and that's all you got to do. Good? You feel it? And that should give you, as long as you have a complete burn, top to bottom. You can actually get under the ligament, Like the ligament runs like this, and if you get under it, we're going to show the audience the picture in a minute. If you get under it, you can actually do this, right? Under the ligament. So you keep the ligament intact, so your joint is fine. There's no instability. You guys see the scars from his prior surgery right there?
Yes, we do.
So he had all this fusion done. I didn't do it. He had a minimally invasive fusion, if there is such a thing. You could see the screws are cannulated. Show us the cannulated screws, Henry. Can you see the x-ray, the last image? See the white arrow?
Yes, we do.
All right, show us the cannulation. See the end of the screw, the tip, how it's hollow right there? And there's like a channel running through the screw. That means they were put in percutaneously. So they put in a guide wire first, and then they ran the screws down over the guide wire. The original system that did that is called the Sextant system by Medtronic. But there's probably other systems now. Look at these incisions, okay? They're 4 millimeters each. 2 of them. And we fixed the SI joint. The SI joints are pretty big. They run right here. SI joint. And like I said, all these doctors, they want to fuse, because there's good money in fusion. Literally tens of thousands of dollars they make, to do fusions. But fusions are not good for patients. We've tried them. They don't work well, and they're very risky of complications like bone fractures, hardware fracture, damaging blood vessels, nerves. I mean, really risky. And there's no reason for anyone to go through that kind of a procedure when you can do what we just did, where you're burning the pain nerves. And this is outpatient. Patient's going to go home in 15 minutes. The last guy we did, the first case for today, he's already gone. He was up walking around, and he's so happy. He said, "Thank you so much." All right. That's it, Henry. Any other questions?
No current questions.
Thanks so much, everybody. Have a great day.